Good morning, everyone, and welcome. My name is Larissa Mooney. I am an addiction psychiatrist and faculty in the Department of Psychiatry. I am so pleased and honored to be introducing your speaker today, Dr. José Flores. Dr. Flores is a child and adolescent psychiatry fellow at UCLA and interested in interventions for youth with co-occurring psychiatric and substance use disorders. Dr. Flores completed medical school and obtained his PhD in epidemiology from Johns Hopkins University. He subsequently went on to complete psychiatry residency and addiction psychiatry fellowship at Yale University. At Yale, he was a T32 postdoc fellow in pediatric neuropsychiatric disorders at the Yale Child Study Center and worked at the VA hospital in West Haven. At the VA, Dr. Flores worked in multiple addiction clinics, including their methadone program. From his work with adolescents and with U.S. veterans, Dr. Flores has developed expertise treating psychiatric disorders and addiction across the lifespan. Dr. Flores is especially interested in transition-aged youth, TAYS. This period of life is characterized by the transition from adolescence into young adulthood, when young people face extraordinary challenges that increase the risk of developing a substance use disorder or severely worsening any existing drug use. As part of his research, Dr. Flores collaborates with me in various trials, testing interventions to treat opioid use disorder in rural settings, cannabis use disorder, and also concurrent use of prescribed opioids with benzodiazepines. Over the past decade, Dr. Flores has completed extensive clinical and formal research training and has made important contributions to the scientific medical literature in both child and addiction psychiatry. He is the recipient of the 2023 NIDA AAAP, which is the American Academy of Addiction Psychiatry Mentored Facilitated Award, the AAAP Renner Travel Award, and was selected as the inaugural Sorensen Child Psychiatry Research Fellow Award, where he will work on a pilot study to study the feasibility of deep TMS for the treatment of cannabis use disorder in young people. It is really my true pleasure to work with Dr. Flores. I feel very lucky. He's a wonderful human being. And I will now pass this over to you, Dr. Flores.
Thank you so much, Dr. Mooney. And I've titled today's presentation, Youth and Opioids, Understanding the Epidemic's Youngest Victims. And I have the pleasure also having my mentor and facilitator, Dr. Larissa Mooney, with me. She's a professor of clinical psychiatry in the Department of Psychiatry here at UCLA. And she is also the division director of addiction psychiatry as well. So thank you so much for being here, Dr. Mooney. Some of the disclosures that we have for the research that we will be presented today. Some of that research was supported by the National Institute on Drug Abuse. I'm also funded by a T32 grant at UCLA. And I've also received funds for dissemination of work from the Clinical Trials Network that I'm very grateful for. And Dr. Mooney has received research support from ALS Pharma, but we're not going to be discussing any agents that came out of that support. So the objectives for today, we will discuss features of adolescence that increase substance use risk, including some features that you may not be aware of. So we will also differentiate between the latest trends in opioid use and opioid misuse or non-medical opioid use, and the comparison to the opioid death rate. And we will also discuss a few tools, screening tools, and at least one harm reduction tool, although I have other resources for you as well. So I'd like to start this talk by just sharing a little bit what led me to be interested in the field of youth substance use. So I think throughout my life, there were several points in my life that highlighted the powerful combination of several factors, a young age and the inexperience that comes with it, the environment, and then within our environment, the relationship that a society has with drugs. And in retrospect, when I was a child, I saw substance use as a distant phenomenon, something that wouldn't happen to me. But as children grow, this phenomenon comes closer and closer until a child has to try their first beer, their first cigarette, the first vape, or their first joint, their first sip of wine. And so I became fascinated by this issue because I've always recognized that adolescents often confront these initial encounters in isolation, or at most, they confront them with peers. But so this was, adolescence to me was always this very vulnerable period. And I really wanted to do something about it. But I think really my interest in youth using substances really increased during my work at the West Haven VA in Connecticut during my addiction residency and addiction psychiatry, when I worked with veterans in Connecticut. And when you see a fellow human being overdosing or suffering extreme severe opioid withdrawal, or when you are spending time in the hospital hoping that your patient doesn't succumb to endocarditis, or worse, when they die due to a fentanyl overdose, I think that's when you instinctively start to ask the question, when did this start? And across the board, the answer to the most catastrophic stories was the same. This started in youth. And this is what brought me to UCLA to pursue further training in child psychiatry, because I thought if the problem arises in youth, then the solutions must also be found in this field. So I want to start with just a definition of human adolescence as a transitional phase from childhood to adulthood, characterized by numerous changes, and many people in the audience know these changes: hormonal, physiological, behavioral, psychological. So interestingly, initially, this stage was thought to be a human-only stage, but now researchers recognize that there's a similar stage across mammalian species and even across other non-human species. And I like this expanded definition by Dr. Natterson Horowitz: the period between onset of puberty and wildhood, when an adult animal emerges. And it just so happens that in humans, our wildhood is adulthood. And I often use diagrams like the shown in the picture, describing the development of brain development of rodents and humans to tell youth why I am advocating for a better relationship with substance and what are the things that I'm trying to protect. So let's briefly touch on the massive structural changes that happen during adolescence. And I'm not going to name all of this, but there are changes in gray matter, synaptic pruning. There are very important changes in white matter, in the organization of white matter. But very importantly, the primitive regions of the brain, like subcortical regions, start maturation much earlier. And the cortical regions, like the prefrontal cortex, lag behind. And what this does is leaves adolescents with a period, the adolescent brain with a period of hyperactivity in the limbic system, with high salience to emotions and high salience to rewards. In addition, the dopaminergic system at this time is increasing maximally. So any experience, any rewarding experience that happens in adolescence is experienced as the best experience of your life. So this also is part of the natural reason why adolescents take risks because they're seeking rewards. And also when you encounter drug, this can become very problematic. So a lot of the research that a lot of the conclusions and observations that we have about how adolescents respond to drugs of abuse come from the broader literature. And in this case, we see that the balance of rewarding experiences to aversive experiences is tipped towards reward. And in fact, in adolescent mice have been shown to have reduced sensitivity to the withdrawal effects of drugs. So they don't experience as much withdrawal. Some of this may have to do with differences in how young animals metabolize drugs due to age. And in the right, I'm showing this peer effect that we see in adolescents. So Dr. Lawrence Steinberg is featured here. He created peer groups of 3 mice raised together. Half were tested as adolescents, half were tested as adults. And then within the adolescent group, half were tested alone and half were tested in the presence of adolescent peers, and the same thing for adults, half tested as alone and half tested with adult peers. And what he found is that if you allow mice to self-ingest alcohol, adolescent mice drink more when they are in the presence of adolescent peers, but adult mice don't necessarily drink more when they're in the presence of adult peers. And so these examples, again, normalize what we observe in adolescents and solidify the idea that the environment and biology are playing a huge role, as opposed to other simplistic views that label substance use as a moral failure, or in the case of youth, as a result of poor parenting. It's also important to understand the evolutionary role of adolescence. This period evolved to develop risk-taking behaviors that aided survival for early humans. Things like hyperactivity, novelty-seeking, and impulsivity. They enhance the exploration of the environment and the acquisition of resources. However, now these same traits have they predispose to substance use. And I wanted to show this amazing fact. Today, puberty occurs increasingly at earlier ages, up to 3 years earlier than 100 years ago. And this has been associated with an earlier initiation and increased frequency of nicotine and alcohol in adolescents. And I happened to bump into this podcast by the UCLA Center for the Developing Adolescent that I highly recommend. This podcast accurately gives examples of adolescents across different species. Penguins, for example, become predator aware. First, they're predator naive, and they become predator aware by taking a risk and swimming towards a shark. And young chimpanzees, this is another example, usually stay with their own group and are usually very terrified of encountering other groups, except for adolescent females who exhibit this risk-taking behavior and go on excursions to other groups during adolescence. And this is serving a role preventing inbreeding. So these changes in risk perception serve the purpose and continue to do so when adolescents take healthy risks. However, when risk-taking and curiosity leads to experimentation with drugs, this has become very dangerous now that drugs are more potent and more lethal. In terms of human studies, these are the three points that I want to highlight. So the early maturation of the subcortical reward system leads to increased incentive salience to rewards. The lower inhibitory control by the prefrontal cortex leads to poor executive control. And the way that it shows in adolescence is the underestimation of risks when they encounter risks. Also, adolescents have been shown to be more prone to habits, and habits are hard to break. And that's another reason why they may be predisposed to substance use. These changes in brain development and biological changes also lead to psychosocial predispositions, like changes in their belief system. So adolescents tend to carry beliefs about their invincibility, something called optimistic bias, which also happens to adults, but happens much more with adolescents and much stronger. Adolescents also, because they tend to take risks, this is very dangerous in the light of the current opioid use landscape, because now we're dealing with a lot of counterfeit pills, and it is even harder to evaluate risk. So adolescents and young adults are less likely to question what they're getting, especially if they look very similar. So for example, on the right, we see this picture of fake Adderall that contains methamphetamine and that is being sold on social media compared to authentic Adderall. So adolescents also might misinterpret risk. So they may not understand that people can overdose by snorting, by smoking, or by taking oral fentanyl. And there is some data indicating that this is happening. Also, the risk of addiction may be perceived as low if they don't use needles, for example. Adolescents tend to have lower experience with drugs, so that leaves adolescents with also a lower opioid tolerance and a high predisposition to die. So I now want to turn quickly to trends in opioid use. As you may be aware, historical data have indicated that drug use among youth after the onset of the COVID-19 pandemic may have been declining. However, due to the rising potency of synthetic opioids and the contamination of the drug market, including the contamination with counterfeit pills and the contamination of other substances with fentanyl, there has been a dramatic increase in deaths due to overdose among adolescents. In addition, we're observing now a return to those pre-pandemic levels of substance use. And I wanna use this device that is symbolized by the CDC as an iceberg to explore the hidden impact of the epidemic. So sometimes we focus only on overdose deaths, but if you can see under the surface, there is a complex chain of consequences that extend far beyond just the immediate loss of life. So for every one opioid overdose death in 2015, the submerged part show 18 people who had a disorder involving, at that time, one of the most dangerous drugs, heroin. 62 people had a substance use disorder involving prescription opioids. 377 people had misused their prescription opioids, and about 3,000 were exposed to prescription opioids. So a huge hidden impact of a single overdose death. So we can think of the iceberg also as a continuum. This is a framework by colleagues at Johns Hopkins, highlighting the multiple points of intervention across this continuum. That includes treatment, includes prevention of lethal overdose, but also incorporates harm reduction and partnerships with people who use drugs. So in this case, our youth should be included in the design of interventions. And these actions are proposed as effective interventions at this time, but they're not being prioritized and they're not being used, but have been very successful in other public health problems like HIV. So now let's go, let's talk about the base of that iceberg. And I just want to give you a sense, we're going to be talking about millions of people and until we get to thousands of deaths. But in this national representative data, 14.7 million visits were associated with opioid prescription to children 13 and 17. And 37.3 million visits were associated with opioid prescriptions to young adults. So comparing the prescriptions given in the ED to outpatient clinics, there was a 6-fold increase among adolescents and a 4-fold increase among young adults. And what this says is that ED physicians still prescribe to adolescents and young adults at similar rates as they do to older patient groups, even though youth do not have the same comorbidity compared to older adults. If we go up in higher risk level and talking about non-medical opioid use, sometimes called opioid misuse, we are still talking about millions of adolescents. About 1.9 million adolescents aged 15 to 17 misuse or use their opioids in a non-medical way. And 5.4 million of young adults misuse opioids. Interestingly here, most opioids were obtained for free back in 2016 from a friend or a relative from a single prescriber, but only a few bought from a dealer or a stranger. And this is where social media is playing a role. Now, many more youth are able to buy opioids from dealers over social media and the dark web. After first opioid use, especially if there's no medical opioid use, the risk of progression to either non-medical opioid use or opioid use disorder is high. So a first-time opioid prescription in high school is already associated with 33% increase in the risk of opioid misuse after high school. And you can see opioid misuse started very early. Half of them start at age 16 to 18. About a third of them start at ages 13 to 15, and about 10 to 11% start even earlier at 10 to 12. And this is also the case for injection drug use. I'll show you in specifically in vulnerable communities. 6 to 9% of youth who misuse opioids develop an opioid use disorder, often within the next year. But if we're able to delay misuse even a year, That delay is also associated with a 5% decrease in the risk of opioid use. So now going up farther in risk level, now we're talking about hundreds of thousands of youth. So the prevalence for all formal full-blown opioid use disorder was estimated at 1% for adolescents 12 to 16 to 17, and to 1.3% for adults 18 to 25. So hundreds of thousands of youth in this group. When we talk about vulnerable communities that have been most impacted, like rural communities, we see that high-risk behavior like injection drug use starts very early too, with 4.6% starting injection drug use at age 10 to 13, 18.9% at ages 14 to 17, and about 43% of them start at ages 18 to 25. So if there is any life history of opioid misuse, that will predict about 50% of cases of opioid misuse in their lifetime. If you detect that, that may mean that 50% of your population is currently misusing opioids. And if you find any lifetime history of injection, 76% of the people who have a lifetime history have injected in the past 30 days. And unfortunately, of those, only 33% are currently receiving standard of care treatment with medications for opioid use disorder. In this graph, I only want to show that under the age of 25, about 50% of all injection initiations occurring in youth under the age of 25. So part of heroin, let's just turn quickly to heroin use, which has dramatically declined. Unfortunately, it is thought to have declined to now it's being replaced with fentanyl. But just to make sure we cover all bases here, heroin use has declined, and now the prevalence is about 0.1% for adolescents, and for young adults it's 0.2%. And it seems to have peaked for youth in the 1990s and early 2000s, but then after 2016 remained steadily low. But I will show you how fentanyl then continued to increase. So now let's talk about the peak of the iceberg, the top of the iceberg, and we're going to talk about drug overdose death rates only among adolescents in this case. So in 2010, there were 518 adolescent deaths due to overdose, corresponding to a rate of 2.40 per 100,000. That rate stayed about the same until 2019. And in 2020, you can see the rate skyrocketing to 4.57 and then continuing to go up to 5.49. The 2019 to 2020 change is of 94% increase, and the 2020 to 2021 represent a further change of 20% increase. And in these slides, I'm just showing you that when you include young adults, so ages 15 to 24, the number of deaths is significantly higher. So remember, we're talking about the peak of this iceberg. So this has to be multiplied by about 3,000 people, leading to millions of people being exposed to drugs. And anything involving fentanyl has either quadrupled or has increased by 6 times in terms of being associated with drug overdose death. And this is from one survey, one study. This is how the fentanyl-specific involved death rate per 100,000 adolescents increase. So you can see a quadrupling in a matter of 3 years. This provides a little bit of a different view. I apologize. So here we can say that around the onset of the COVID-19 pandemic, you can see fentanyl then suddenly increasing to represent 70% or more of adolescent deaths compared to all of these other substances, including prescription opioids and heroin that have remained relatively low, but have been replaced by fentanyl. So now I want to talk about the reasons why fentanyl is killing so many youth. So first, fentanyl is very potent. You only need a very small dose to die, especially if you don't have tolerance. So estimated to be 50 to 100 times more potent than morphine. It is profitable, so a small amount of the quantity of the drug produces significant amount of doses. It is also widespread. Available there's widespread availability, and now there's the proliferation of counterfeit pills resembling prescription drugs but containing illicitly manufactured fentanyl. And now we have it's a lot easier to purchase pills through social media. So this caught the attention of the New York Times, and I really recommend this article. I wanted to put more images here but to respect the victims, I chose not to. So in this article, it describes teenagers and young adults turning to Snapchat, TikTok, and other social media apps to buy Percocet and Xanax. And if you think about it, if what you're trying to buy is Adderall, but you get methamphetamine, that's a huge problem. But if you're trying to buy Percocet and what you get is fentanyl, you might overdose with a single counterfeit pill. And also, if you want to buy Xanax, and now a lot of youth are socialized to sharing Xanax, to getting Xanax, you might not have any tolerance to opioids. So this is a death sentence for some people. And if we look at another database, I thought this was very interesting. This a database of ages 18 to 19 that documented the circumstances in which deaths occur. So for about 2,000 deaths, there was evidence of counterfeit pill evidence in about a quarter of those deaths. 60% of youth died at home, and sadly there were bystanders in about 67% of cases. But if there was a bystander, also in 67% of cases, there was no bystander response reported. And naloxone, a life-saving medication, was only administered in 30% of deaths. The methods of using that resulted in a deadly overdose were ingestion, smoking, and snorting at about the same prevalence here. And so ingestion, smoking, and snorting. Injection was only about in 7 to 8% of cases, only among older adolescents. But you can see that people may misestimating the risk, maybe misestimating the risk of ingestion, smoking, and snorting. The DEA says that these pills are made by 2 large Mexican drug cartels, and they're made identical to look identical to real prescription medications, including Oxycontin, Percocet, Xanax, and Adderall. And in 2021, the DEA seized more than 20 million fake pills, but this is thought to only be a portion of the pills out there. And in 2021, the DEA launched the One Pill Can Kill a public awareness campaign to educate Americans about fake pills. They also published this emoji drug code, which is how drug dealers on social media, they advertise and how young people might purchase drugs. And they attempt to use emojis to try to not be detected by regulatory people on the platforms. Dr. McKay from University of California in San Diego, in this New York Times article, says that there are drug sellers on every social media: Instagram, Facebook, Twitter, Snapchat, Pinterest, TikTok, and even emerging platforms like Discord or Telegram. So as long as a child is in one of these platforms, they're going to have the potential to be exposed to drug sellers. Okay, I don't have a lot of time to speak about screening, but what I wanted to give the audience is at least 4 tools that actually ask about prescription medications. This is the S2BI, BSTAT, Kraft, which is also a screening tool and an assessment, and TAPS. Those are 4 screening tools that you can use that directly ask about prescription medications. Now, not all professional bodies recommend screening for adolescents with for substance. For instance, the U.S. Preventive Services Task Force in the latest guidelines concluded that there is insufficient evidence to assess the benefits or harms of screening in adolescents and only recommended drug screening for adults. The American Academy of Family Physicians even said that there is not even sufficient evidence for screening adults except for opioid use disorder, and gave a C recommendation only for adults. They don't have a statement for adolescents. And part of the reason why these professional bodies have not endorsed screening is because screening, like other interventions, cannot happen in a vacuum. Screening and brief interventions for mental health, for other substance use comorbidities they must happen in a coordinated and comprehensive framework, where you can establish confidentiality, you can do screening, you are knowledgeable about brief interventions. If you cannot prescribe medications for opioid use disorder for some reason, then you have the ability to refer to either mental health professionals or addiction professionals that can do it. And then we need to also emphasize ways to improve retention. So these are some ways to improve the effectiveness of this whole process, familiarizing yourself with screening and brief interventions. And I highly want to suggest including harm reduction interventions in your conversation with adults, but also increase your familiarity with buprenorphine and medications for opioid use disorder, increase your knowledge of local SUD and mental health services for youth, increase education and access to naloxone, including for parents, and identify interventions that delay opioid initiation that improve retention. This is one harm reduction tool that I wanted to share with everybody. It's called the Safety First Curriculum, and it's a really nice curriculum that you can advise to parents, to youth, to educators, and it covers harm reduction principles to use drugs in the safest way possible. It does encourage abstinence if the child's not using, but it also gives these principles of harm reduction to reduce risk. And it does cover prescription and opioids, and including fentanyl. So I think this is a great resource. All right, and just to briefly name the effectiveness of the medications for opioid use disorder. So buprenorphine is approved for individuals 16 and up with parental consent. We do have a bill in California that is asking for this medication to be for patients 16 and up to be able to self-consent to buprenorphine. It was doing really well until I checked. And the benefits are improved opioid abstinence and also improved retention, even higher than in adult trials. It also, longer use of buprenorphine is correlated with lower injection drug use. And right now in the country, this is not being prioritized. If the adolescents or youth receive buprenorphine, they might receive it for short periods of time and not for ongoing treatment. The side effects are minor: headaches, constipation, insomnia. There's some risk like drug diversion. You have to measure liver enzymes from time to time, and there's a slight risk of QT interval elevation. And also some concerns about the effects of neurodevelopment because buprenorphine is still a partial agonist. In terms of naltrexone, the data shows better retention with extended release naltrexone. Oral naltrexone does not seem to be effective due to adherence issues, but there is low potential for misuse or diversion, and it reduces alcohol cravings, and so it is suitable for co-occurring alcohol use disorder. The induction may be more difficult, and there are risks if the patient misses doses because they're going to have a lower tolerance. So if they relapse, that's their increased risk for overdose. Methadone is effective too. There is better retention and reduced opioid use in youth, and also efficacious in pregnant women. So it's important to consider it for pregnant youth. Restrictions are, there are restrictions for patients under 18. Admissions to an opioid treatment program requires parental consent and proof of 2 prior treatment failures within the past 12 months. So it's a fail first, fail twice approach. And this is mainly because this is a full agonist and there are risks of respiratory depression, sedation, diversion, QT prolongation, and others. Also, we have limited dosing data for youth. Okay, so now after that, I just want to quickly share some research that we have been conducting with Dr. Mooney on rural youth, one of the most affected populations. So in this paper that is currently under review, the way that we set the stage was we show that there was a significant increase in opioid use disorder between 2020 and 2021 in young adults and adults 26 or over. There was a mortality increase as well. Treatment availability is an issue because the majority of people with opioid use disorder, especially youth, don't receive effective medications for opioid use disorder. And also there are challenges in rural areas. There's 35 higher risk of misuse in rural youth, and there's earlier initiation and injection drug use, as well as increased risk of HIV and hepatitis C. Also, rural areas face more problems because they might lack mental health services and access to MOUD. So the focus of this research was to examine the prevalence of OUD and also the practices in terms of prescribing MOUD during the study, comparing TAY, transition age youth, to older adults. The study type was a secondary data analysis. The data came from a large feasibility trial. The trial itself, the parent trial, was trying to expand access to MOUD by implementing a care coordination model, pairing primary care sites with an external telemedicine vendor. And this was done in rural clinics, but coincided with the start of the COVID-19 pandemic. Every clinic received the intervention. The outcomes that we were looking at are opioid use disorder diagnosis during the 15 months, prescription, whether the odds of prescription of medications for opioid use disorder during the 15-month study period, and also the number of days. If people were prescribed MOUD, how many days did they receive MOUD? The independent variable was age, young age compared to adults over 26, and we controlled for sex, race, ethnicity, insurance, mental health comorbidities, and how much time each participant was followed in the study. This is the table of characteristics, and you see that young adults here have a higher prevalence of female participants. They have a slightly higher proportion of Black or African American participants, and adults older than 26 have a slightly higher proportion of white participants. TAY also had a slightly higher proportion of Latinos or Hispanics, and they also had a higher rate of mental health, of at least having one diagnosis, one mental health comorbidity diagnosis. There were differences in insurance too, higher rates of uninsured participants, higher rate of Medicaid, and higher rates of private among transition age youth. These are the results of the study. So we can see here in the main results in the mixed effects regression models, we discovered that after statistical adjustment, there was a significant decrease in the odds of being diagnosed with opioid use disorder, comparing young adults to adults, which coincides with the literature. However, we didn't observe any differences, significant differences between young adults and adults over 26 in terms of the likelihood of receiving MOUD. But we did observe significant differences if you received MOUD. TAY, young adults, received fewer days of MOUD, ranging from 43 fewer days to 63, about 2 months fewer rates of MOUD. So this is concerning because of it can signify problems with retention. We asked the same question. In this case, this is survival analysis, and the dependent variable is the time until continuous prescription of MOUD is first broken after following participants for 90 days. And so you can see here the curves start to separate, indicating that there is a higher risk, a higher hazard of experiencing a break in MOUD with a hazard ratio of 1.49, making TAY having a higher hazard of having a break in their continuous prescription. So this should be coming soon, hopefully. But the conclusions are that OUD prevalence was lower among TAY compared to adults 26 or over, but the rates of MOUD prescription did not differ significantly from older adults in rural settings. However, when they did receive MOUD, TAY had fewer days on MOUD, indicating possible challenge in treatment adherence and retention. So our study calls for targeted interventions to study and address the issues related to lower retention and adherence in youth in MOUD treatment. And we suggest further research because these were participants in an intervention, and we would love for this to be validated in a general rural sample. And lastly, what I briefly want to touch on is another project that we have with Dr. Mooney, where we're attempting to disseminate materials about opioid use in youth to 4 key stakeholders. So this is from that mentor-facilitated award. We received some funds to disseminate evidence-based information about opioid use in youth to youth who use opioids, parents, physicians, and healthcare educators. And we're doing this through the expansion of a webinar series for primary care and healthcare providers through social media, and we're developing a centralized website for resources. And this is how we have contributed to with the webinar expansion. We work with the Matt Echo Clinic on a presentation on current trends, educating them about fentanyl, counterfeit pills, all of that. And also we work with the Provider Support Initiative, talking about the whole process of screening. This is the website, and it just shows you like that all these 4 populations, educators, parents, patients, and healthcare providers, will have their own hub for resources. And this is an example for the resources that will be disseminated to providers. Clinical tools, we will recommend issues on articles on medication for opioid use disorder, webinars, and for education and training, screening tools, anything related to referral to treatment and overdose prevention. And then these are examples of the social media dissemination strategies, where we're going to focus on sending a message to youth and parents about the dangers of purchasing pills on the web, also screening tools to providers and other useful resources. And I think that's it. Thank you so much for your time and attention. And these are the people that I would like to acknowledge.
Thank you so much, Dr. Flores, for an excellent and enlightening presentation. Very relevant and very timely, really, highlighting the change in the drug landscape and the particular dangers this poses to youth who are, of course, accessing social media and just maybe unaware of the risk of what they're choosing or selecting may not be what they're receiving. And fentanyl is really driving and fueling the opioid epidemic in this country currently. And this is despite, as you mentioned, really some statistics that show decline in rates of drug use in teens overall, but the overdose deaths are on the rise. There have actually been some theories suggested about why is substance use declining in youth, and some of this may have to do with social media and internet and the time that's being spent on devices as opposed to and interacting in person and using substances. We do have one question in the chat thus far that I can read aloud. Can you elaborate on how temperament impacts risk? in youth? For example, novelty seeking seems to be familial. Is there a way to potentially modify this risk factor to, or this factor to attenuate risk?
Mm-hmm. So that's a wonderful question. I think it gets to this issue that I raised earlier, that this individual or familiar or genetic or evolutionary traits, they need to be expressed somehow. So I think all of us as adolescents have these traits, these novelty-seeking traits, these hyperactive traits. And obviously this combines with temperament, right? But it also combines with the resources that a family can provide for their adolescents. So I think if, one way is you allow the expression of this novelty seeking, but you allow the adolescent to have healthy novelty seeking experience. So as opposed to if you see that the adolescent has this type of temperament, and if you don't do anything, the adolescent is more likely to go for anything and bump accidentally, or because of of their environment, they might try drugs because of their novelty seeking. So I think it's even more important for people with specific temperaments, and also specific mental health disorders, right? So ADHD comes to mind, right? So it is our ability to, as adults, to help youth engage in that natural novelty-seeking aspect that they have, but with healthy experiences. And this is not going to be, sometimes families, especially with low resources, right? This is why substance use is much more prevalent in certain socioeconomic settings, is because families may not have the power to help with their environment and make available more healthy activities for
Yes.
their. Mm-hmm. But that's
yes, I see what you're saying. I mean, it sounds like structure their time to the extent possible, but that also requires resources. And then for someone who's particularly risk-seeking, thrill-seeking, those activities might need to be receptive to that trait, like, I don't know, surfing lessons or
sports,
membership at the trampoline park. Maybe those have other risks, but it could be an outlet for some of that natural
right.
Novelty seeking.
Exactly, Dr. Mooney. And I think, but if we fail to provide a structure, then novelty seeking is not simply going to go away.
Right, exactly.
If it does go away, it will be after many, like risk-taking behaviors have already taught the adolescent.
Yeah. Right, they're going to find an outlet for that.
Right.
Novelty seeking. There are a few more questions in the chat, so let's see if we can get through them.
I love
yeah.
the second question. I can see it. Is that?
Oh, you can see it. Yeah, about childhood trauma.
Right, childhood trauma. So extremely important. And, I still, when I was working with veterans, PTSD was extremely prevalent, right? And a lot of traumatic experiences occurred in childhood. And when they did occur in childhood, they had a huge impact in both adolescent substance use and then this prolongation of chronic severe substance use. So this is incredibly important. And in fact, in that research paper that I show about rural communities, most of the participants reporting injection reported a history of trauma in early age. So hugely important. Yes. And people, anyone with trauma might be also trying. There are all of these hypotheses. Are you self-medicating your trauma? Have you not had access to some trauma-informed psychotherapy or access to care for your trauma, right? So it just lives within you. And yes, if you don't do anything about it, yes, you're more likely to cope with substances. Absolutely.
Yeah, a definite risk factor. Another question is about, in addition to Narcan distribution, provision and education around naloxone for overdose prevention. I'm curious about the dissemination of fentanyl test strips to youth from primary care clinics and schools? Should we be giving those out?
Right. So the conversation about fentanyl test strips is very interesting, and part of so they have changed in the sensitivity to detect fentanyl. There are some organizations now that claim to have standardized the process, but this is not regulated by anyone, right? This is not regulated by the government or anything. So in some cases, I have talked to colleagues who have recommended this, but sometimes they're afraid of the strips representing or being misrepresented as paraphernalia. So we need to do a lot more work with the schools to make sure that they understand this harm reduction strategy. I think eventually I would love to see test strips being not stigmatizing, not stigmatizing my patients, right? Because the other issue is to also to be able to use a test strip, you need to learn to use it. It's not, there is a dilution component. You have to dilute the drug correctly. And as long as we have this stigmatized view of substances, then we're not going to be able to show youth how to use these strips correctly. So that's my take on it. But I think it's a wonderful, I think that's where we should be headed. But we're going to need we're going to need the approval of schools. We're going to need the approval of other officials, right? And parents as well.
Mm-hmm, mm-hmm. Yes, and also another factor I've heard about is sometimes if you've used the strip incorrectly and you have a negative result, it may give a false sense of confidence. So part of the education also for the person using it is this will reduce risk. You're testing now your drugs, but just because it's negative, still have caution that it could be that the strip didn't work or it wasn't the test wasn't done correctly.
Right. What I did see is that the process of diluting your drug, now the recommendations I forget the name of the company, but I think they have been working with test strips for at least 2 decades. And now they include like a little measurement spoon, and you have to put 5 really tiny.
Yeah.
After crushing your drug, you put 5 small tiny scoops of that in a cup of a regular soda bottle, and that is the right dilution amount.
Mm-hmm.
So right now it's getting easier, but I think there's still some ways to go, especially in lowering the stigma so that people with strips are not stigmatized, right?
Yes.
Yeah. Mm-hmm.
So still, we have 3 more questions here. One is around school settings. What sort of programming and education should be incorporated into schools to prepare or educate children about substances and potential for misuse? What are some environmental protective factors that the school setting can provide?
Sure. I think in terms of school, is extremely important that we make partnerships with educators and and with parents, right? And we educate parents about the benefits and the life-saving intervention that is harm reduction. I think if our schools include more information about harm reduction that is not sensationalized, that teens are actually going to accept as true, right? Because that's part of the problem, right? Like that we sometimes teach abstinence or tell kids that there's no way that people can use safely. And so they end up not thinking about how to use safely. So I think that changes in curriculum should be geared towards giving kids, even at earlier ages, starting to talk about drugs, starting to talk about fentanyl earlier in ages. So that would have to be a revamping of the drug use curriculum and for youth. I would advocate for it to start even earlier. And I think protective factors are when you have teachers and when you have school directors that are that understand the impact of harm reduction techniques, I think that that's a very good sign, and it shows it's associated with less stigmatizing environment, and that people just acknowledge that drugs may be part of the environment, right? So I think that also interventions that involve peers are extremely important, as we saw even in mice, there's a peer effect, right? So
Yeah.
I think some schools have started in LA County to implement peer-based interventions with senior and juniors teaching to freshmen and sophomores. I think that that's a wonderful step in the right direction.
Wonderful, thank you. One more question, well, two more, but let's see what we can get to. We're almost at time. What about Never Use Alone hotline? Do you recommend that for teens?
So it's an interesting question. I don't know the data. I don't know the data for how teens are accessing this, and whether it is as efficacious for youth. I would have to look at it, but I think for adults it's a good option. I just don't know. Teens have fewer resources. I don't know if they would be able to if they have a phone. Also, it's more difficult for them to I don't know, to be on the phone while using, I think. So I'm not sure about this. This is a
Right.
really good question.
Conceptually, it makes sense, but
Right.
how is it acceptable, adoptable, and what are the actual impacts on outcomes?
But it's a great point, because as we saw, 60% or more youth die in their homes, right? Even if there's a bystander present, right? So they're not using with another peer necessarily.
Yeah.
Right? There are youth that use alone, and in that case, I mean, it could be wonderful if this is actually, if we can prove that this is efficacious, for sure.
Yeah, right. If someone else is on the line at least, and could be harm reduction strategy. So thank you everyone for your time today and for this engaging discussion. Dr. Flores, I have copied one additional question that you could answer by email. So I'll send that to you after the talk. And thanks again for all of your participation. Have a wonderful rest of your day.
Thank you very much. Thank you, Dr. Mooney.